Dr. Bailey, welcome. We've initiated a project to collect reminiscences and thoughts from pioneers such as yourself who've been an active part of the evolution of the field of heart transplantation as well as of the society. And to that end, it's a great pleasure to include you in this process.
Well, thank you for including me, Lori. I'm delighted to be here with you.
It would be incomplete without you. So I'd like to just talk a little bit about your education.
Oh, yeah.
If you don't mind. You did your undergraduate studies in Maryland, I understand, after which you attended Loma Linda University School of Medicine, thus commencing a long-standing connection with that institution. And you graduated from medical school in 1969. So you would have been a student when the first heart transplant was performed in Cape Town in 1967. What do you remember about that and the impressions of that time?
You know, I have a fairly vivid recollection of that event. I had known what was happening on the Stanford campus when I was in school. I'd actually come to med school to be a heart surgeon, oddly enough, strangely enough. I mean, I was sort of brash, perhaps, but it was true. Nevertheless, in 1967, 68, I was in the laboratory as a student. I had managed to get a 3-month rotation in the laboratory with one of the vascular professors who was transplanting kidneys in the lab in those days. And so I was learning how to do that in the lab and learning something of the immunology and the immunosuppression for that. And then out of nowhere, this story came up out of South Africa that Chris Barnard had transplanted a heart. Of course, I took interest immediately. And we began to shift our interest in the laboratory at Loma Linda as early as that towards heart transplantation. That's how infectious it was.
It was an amazing time. It must have been.
It was, and we were, one of the projects I even reported on later was how to preserve a heart in vitro, essentially, so that it could be available for transplantation. And during that phase, I had the privilege of going up to the Stanford campus, and I spent a day in their laboratory as a student, and there watched the brilliant Ed Stinson sew a heart in a dog, and I was stunned. Of course, he made everything look simple. He's a brilliant operator, and but the whole concept just sort of stuck with me.
So you were already interested. So these events actually guided your future career. I mean, they captured your imagination and guided your career, even as young as a medical student.
I was convinced that heart transplantation would be part of life as a heart surgeon eventually. Didn't know exactly when, but the idea of it was sure solid. And then this stunning thing that Chris Barnard did in Cape Town just lit the candle, so to speak, for a while.
So you finished your training in cardiac surgery, and you spent some time at the Hospital for Sick Children in Toronto. And so you were already interested in the application of these technologies to the pediatric population, I guess.
That's true. And I think it was at the Hospital for Sick Children that it occurred to me that newborn babies might benefit from this technology as well. By that time, heart transplantation in young adults was beginning to get some traction. And what I observed at sick kids was that the single ventricle babies with hypoplastic left heart syndrome would be born and they would die all within the same week ordinarily, no matter what we did. And so in the back of my mind, the idea was to put transplantation together with these babies, and I didn't know a lot about their naive immune systems at the time, perhaps still don't, but it seemed like a natural setting for transplantation.
So if we backtrack just a little bit, to the mid-1960s, Dr. Adrian Kantrovich was also doing seminal work looking at, or perhaps trying to find options for these infants who really had no hope of any survival. How did that experience, I mean, ultimately he did do a transplant only days, I think, after the Cape Town transplant, and this was unsuccessful, but how did that impact your evolution as a pediatric cardiac
You know, oddly
surgeon?
enough, I learned to admire Kandrowitz much later, and for other things than for his enormous effort in trying to sort out baby heart transplants. He was perhaps the most ready of anybody to do that in those early days, but perhaps somewhat ill-equipped with stuff to get it done. He did that operation off pump, as you had to do in those days with little babies. And I suspect it went along quite well. I think he was good at what he did. And to this day, it's unclear why that didn't work out. It should have.
It should have.
And why he lost enthusiasm for it.
Well, that was one of my questions to you. Do you think he should have persisted? Do you think it would have been successful?
Well, I think so. Yeah, he should have. But he, as you know, when he did that transplant, he sent out a whole net, maybe 50 letters and, or telegrams went out to centers. Was there a center anywhere with a brain absent baby? And one appeared, a response appeared from Philadelphia, a child of an attorney of all things. And that baby was then transferred to New York for that transplant. And I think in the back of his mind, he couldn't quite envision how he was going to find donors for babies. And he and his brother had these other ideas cooking.
Yeah.
He was a fertile-minded fellow, and they went on down that path of treating heart failure.
Well, I guess he also faced quite a lot of controversy about the use of anencephalic infants. There wasn't unanimous support that was, even back then, that was the right
I'm sure he
source
did.
of donor.
But a lot of that reaction, I think, was largely limited to the Northeast, perhaps, maybe even just New York and around that area. It didn't get the same broad coverage that Barnard's transplant did in South Africa. So most of us never heard of the baby 3 days later, unless you lived around there and were in that news sector. You just didn't hear about it.
That in itself is interesting, don't you think? And you wonder, something that has troubled me since I was a trainee in pediatric cardiology is these babies, I mean, 100% of them would die.
Yeah.
There was no other option.
Exactly.
And yet it was almost, it was just sort of an accepted fact that, well, there wasn't much to do.
You know, we were just going to brush them aside.
Right.
And when I was in Sick Kids, we'd have our Monday afternoon meetings together with cardiologists and surgeons. And these babies would be presented as just matter of fact, and then essentially brushed aside.
With a shrug. Well, what are you going to do?
Nothing to do for them. Well, that didn't appeal to me as a fledgling, and even today it doesn't appeal to me very much.
I understand that very well. Taking us back to those early days, though, the 1970s, particularly the early 70s, was a pretty bleak time as heart transplantation started to evolve. So you would have still been in your surgical training at that time, I guess, but you'd already had this idea that transplantation was going somewhere. Did your resolve or your enthusiasm for the field wane a little bit during those early years? Because it was a really bleak time, wasn't it?
Yeah, it was a bleak time for heart transplantation.
For heart transplantation,
at least. And other organs were being transplanted with some success in those days. But I must say, I had enough diversions in my life coming up through general surgery training that I guess I just lost touch with heart transplantation for a while as something that was important that I would get involved with, importantly, for that period of time.
So in the late 1970s then and the early 80s, as the field continued to kind of show a resurgence and move forward, and then eventually with the introduction of cyclosporin, there was tremendous growth, of course, and progress in adult transplantation. And then in June of 1984, Dr. Eric Rose performed a transplant in a 4-year-old with failed palliation of congenital heart disease. How was that? How did that impact what you were doing at the time? And
Well, I knew that Reemsma and Eric and the group there in New York were moving in the direction of, and I think it sort of validated my effort to keep a laboratory moving in the direction of heart transplantation in infancy at home. I felt that if we were going to do newborn transplants, and that's where I had focused, that we needed to show some evidence that it was a worthwhile endeavor in the laboratory first. I know Kantrowitz had covered a lot of that territory with puppies many years before, but I had to convince our own environment that it was a worthwhile endeavor.
so you had a very active lab for a number of years using sheep and goats, I think.
That's
Is
right.
that right?
Starting in about, I think we did our first newborn transplants in animals in about 1978. And I've lost track of when Eric's transplant was in the 4-year-old.
June 1984.
84, yeah, so it was some years later.
And in your early experiments, what did you use for, how did you approach immunosuppression? There wasn't much available then.
There wasn't much. We tried different ways to deplete T cells in very peculiar ways that it would make you laugh today. But none of it worked, is the bottom line. The experimental animals lived about the same length of time the controls did, which was still extraordinary. They were living 2.5 months on average with nothing.
With nothing.
With no immunoregulation whatsoever. And then I met Jean Barral in Houston at a cyclosporin meeting. I guess what sort of was a cyclosporin meeting there, and asked if there was some way we could get our hands on that drug. And I had a bright young fellow, Francois Lecoeur-Guillet, was in the lab at that time with me, and he was wondering why we didn't try cyclosporin. So between the two of us, we managed to get cyclosporin sent over to us from Basel at no cost, which was nice, to the laboratory. And that transformed everything. We could get animals to regularly survive to adulthood and actually live to a ripe old age. I think some of them were tolerant because our ability to monitor their immunosuppression was limited.
I'm sure it was, yeah.
And we just gave them empiric doses, very little at that, once a day. And you had to inject them each day.
In these animal experiments, what was the size of the transplants that you were dealing with, both the recipient and the donor organ?
Well, the animals were about 3.5 to 4 kilos, and very similar to newborn babies. I mean, I felt right at home in the laboratory. In fact, I often said it was easier to do neonatal heart surgery in the lab sometimes than it was up in the operating rooms of the hospital.
I'm sure that's the case.
You had more control over it.
Right. So again, at the time in the early 1980s, then the surgical techniques for infant heart transplantation were really just evolving as well, wouldn't you say?
Well, they were, so that you get regular survival. We would anticipate that the animals would survive, and we treated them as if they were human babies, really. And so we put that kind of effort with them. Nancy would let me sleep down there with the animals once in a while, not come home, for instance. So until we got a system worked out, and then I didn't have to do that very much.
So, so the kinds of things that you were able, from a surgical perspective, from technique
Yeah.
and so on, the kinds of things that were going on the clinical side at that time, what kinds of surgeries were you doing that were non-transplant surgeries in that size infant?
We were doing mustard operations regularly in newborns. We were doing total anomalous pulmonary venous connection repairs. We were still palliating a number of children with single ventricle, with shunts or bands or whatnot. So we had a regular practice going in
Right.
newborn surgery, and we were having pretty good outcomes.
And the arterial switch had not yet come along for
Arterial switch
transposition.
wasn't even there.
That
Do you know,
wasn't
I
there.
think that we may have been the first to do Mustard's operation in a newborn. In fact, I think we ran up quite a little series before anybody else ever did one in a newborn. But when I was in training, it occurred to me that there was no reason to postpone the Mustard operation and accept a nutrition while you were waiting, that we could do those, and you wouldn't have to palliate them
Right.
with any kind of a procedure other than a balloon. And you could go right straight to the operating room, and we did that.
So the surgical techniques were really coming along pretty well.
We'd gotten quite comfortable clinically
Yeah.
with neonatal surgery
And
by that time.
where was the growth of the clinical neonatal surgery program compared to other programs around the country for neonatal surgery?
Well, I think we were never put off by operating on newborns from the very start.
Which is quite different, isn't it?
It is. It just, when I was in training up at Sick Kids, there was a little hesitancy towards doing it. We'd do it when we'd have to. But while I was there, I made up my mind that there was no need to not do it when it was regularly necessary. So we began to apply surgery to newborns from the very start in 1976. Did the first Mustard operations in newborns in April of 1976. I'll never forget it because it was sort of stunning to the Loma Linda environment, because that was new to them there. But I'd been trained so well in Toronto that it was just a natural for me.
Well, you had some excellent teachers in Toronto, as I
Yes.
recall.
Well, Mustard was one of them.
Right.
And Bill Williams
And George
of
Tressler would
course.
have all been teaching you some
George
of those
was the
techniques.
stalwart
Yes,
teacher.
He was. So those early animal experiments helped, and then, but we always come back to the hypoplast. We always come back to the infant with hypoplastic left heart syndrome. And although newborn surgery was advancing, this was still widely considered the worst heart disease that there was. Would that be fair to say?
Kind of the last frontier, if you will. I knew by the early 80s of Bill Norwood's effort in Boston to try to make something of it. In fact, I'd learned a little bit about what he was doing while I was still in training. I think he had developed an interest, whether he had really operated much yet. By the time I was getting out of training, he had already begun to develop an interest in hypoplastic left heart syndrome and trying to palliate those children in the mid to late 70s. And he actually, by 78 or 79, got a handful of those kids to survive.
For a while.
For a while.
Yeah,
Uh-huh.
yeah. So then we come to 1984. It astonishes me still to consider for how many years, as we previously said, these children were just kind of excluded from consideration of really important therapeutic endeavors. And I'm sort of the mind that sometimes patients who have compellingly high risk of death present you with opportunities to move forward in the field and justify the use of extraordinary measures.
Yeah.
So take us to October of 1984, and baby Faye soon became a household word, with an unprecedented amount of publicity. So this was a baby with hypoplastic left heart syndrome, and how did she come to your attention?
She was. We had developed a protocol that we'd submitted to our institutional review board to do cross-species transplantation in newborns, something like 14 months earlier. And so the discussion was already underway. It was in the mix. It took a long while. And we had several internal reviewers go through it with a fine-tooth comb. And then we had several external reviewers come by and evaluate the process as well.
Including Stuart Jameson, I think.
Yes.
Yes.
Yes, that's right. Stu Jameson came. One of them, Sandy Nelson Canarella, whom you know, ended up joining us in the end. And another nephrologist from UCLA. I'm blanking on his name right now. I shouldn't, but I came out and spent time on our campus and reviewed the protocol.
And this was based on the experimental work that had been done over the years in your
Yes, and making suggestions about how the protocol could be viewed and modified as being appropriate, I would say. But as you said, here are babies who are dying. And so ethically speaking, it was a little bit easier discussion to do something rather than nothing. It was the something that kept tripping the powers that be for a while.
Well, you know, we faced a similar ethical discussion some years later when we instituted ABO-incompatible transplantation. For very similar reasons, that there was a compelling need to do something for these children who had an extraordinarily high chance of dying.
Still dying.
And still did,
Yeah.
and still did. So as you moved toward that, how did the plan get put into motion then? And
well, we had the institutional review board had made a lot of progress, and we were towards the end of that process. And in fact, it was right about then that Magda Yacoub transplanted a baby in London in the summer of 1984 with hypoplastic left heart syndrome. And unfortunately, that baby didn't survive either. But it sort of stimulated us to keep moving. We were moving in the right direction, we thought.
do you recall where, how he obtained a donor organ, what the circumstances were?
Yeah, I think I think that baby came out of the Netherlands.
Mm-hmm.
It was a Dutch baby, I'm not sure which gender, that they transplanted into
Mm-hmm.
the baby there in London. I believe I'm right on that. But at home, I was just walking down the hall one day towards the end of this process, and one of our pediatric cardiologists met me in the hall, and he said, so how's it coming? And that's how he would talk, with your transplant project. I said, well, I think we're making progress. And he said, well, we just diagnosed a baby. Do you think you're ready? And I thought, well, you know, I think perhaps we are. I think we are. We just essentially gotten approval from the IRB to go forward. It hadn't yet been stamped completely. And so I said, I'll investigate it. We'll see. Where is the baby? I said, well, the mother has taken the baby back up onto the high desert. And I said, well, perhaps we can contact her and see if she has any interest at all in something like this. Meanwhile, the IRB can make its judgment, its decision. And it did, and we did. One of the neonatologists called the mother and said, if you have any interest, this is a protocol that's in place, so we can start somewhere with your baby. And baby was named Stephanie Faye. Right. So she brought the baby back down, along with the baby's father. They weren't married at the time. And we had long discussions, and she said, yes, she'd like to go forward. Well, that really put the heat on us at that point. And I called Sandy Nelson Canarella, the immunologist. He was over in New York. And she was getting on the next plane, essentially, to come out and help. And we spent 6 or so days, as I recall, about a week, trying to keep baby Faye alive. That was no mean chore, because we didn't know what to do. We didn't know exactly how to do that. And Sandy got busy and was trying to select one of a panel of baboons that we'd already organized in advance of all this. And in the end, that's how baby Faye came to be. The night she was dying, for sure, we chose a donor and took her to the operating room the next morning. Happened to be a Friday morning, as I recall. There was some relief in that fact, that it was a Friday. I do believe, because maybe the media attention would have been even worse if it hadn't been a weekend. I don't know. I don't know how it could have been any worse, really.
Well, it was pretty. So the first events then were her actual operative procedure, from what I understand, proceeded pretty well, didn't it?
We were so ready to do that operation.
Mm-hmm.
I don't say that arrogantly at all, but we'd gone through that routine. The technical part of it, aside from the fact that we were reconstructing the aortic arch, which was a little bit different for us, the rest of it just all fell right in place.
So what elicited this firestorm? When do you think? I mean, you've had, I'm sure, looked back on this many times, but why do you think it became so hysterical?
Well, two things. One is it was a newborn baby. And I think the thought was out there that we'd taken advantage of some poor family, and we were just using this baby. And you can see how that might be the case. And the other was the fact that we had used baboon as the donor. And there's a whole sector of folks out there that don't like that idea either.
So do you think, I mean, there was the controversy, it seemed to me in looking back through it, came from every different direction. And part of it was the animal rights group of people, and part of it was, as you say, perhaps a vulnerable infant. But of course, remembering that these are the children who have no other options. And I'm very reluctant to think about the fact that we deny opportunities under the premise that we're protecting children sometimes, when that really hampers progress in the field. And that's sort of been that way for years. That's been a barrier to overcome, hasn't it?
Part of it was that particularly the television people, but also the newspapers, needed commentary to carry a story. And so there was a lot of commentary by folks who weren't as intimate with the field as you and I might have been even then. And so there was perhaps a lot of criticism just out of well-meaning ignorance, essentially. Some of it was useful, I'm sure, and I tried to listen to some of the useful criticism along the way. But quite frankly, I didn't hear very much of it until much later.
Is that right?
I was busy taking care of baby Faye.
So tell us how those few weeks went then. Did you feel a little bit protected from the, as you say, the
The
melee?
campus, the campus just gelled somehow, and its sort of resistance to being impaled from the outside, and its protection of this life, this baby up there. And so I didn't have to do much except what I just normally did every day, only I just did more of it. Everybody just fell in place, it seemed. The campus was unified about giving this the best shot we could give it for this baby. And we were doing really quite well with baby Faye.
So what were you treating her with?
Cyclosporin?
And it was an intramuscular injection at that time, I think?
Well, we were
or
giving it intravenously.
Intravenously, yeah.
And I had the bright idea, it was lipophilic, and that we could nourish the baby and give the cyclosporin all at the same time, just by putting in some intralipid. And so that's how it was, the IVs was set up to deliver the cyclosporin continuously, and lipid. And that was one problem we ran into. We did have an incident where a syringe full of this business went in, of lipid, and we immediately exchanged baby Faye. You know, and looking back, that was still the right thing to do. If we had known enough, we might have been exchanging her regularly anyway.
Yeah.
Probably should have been. We didn't know enough to do that, except for this one incident.
Yeah.
And so I don't know what role that exchange transfusion played in her survival, whether it added or subtracted days to her. I do know that the lipid played harshly with her and may have in some level eventually contributed to her death. But her death can't be explained entirely on an immunologic basis. In fact, hardly at all. There was very little immunoglobulin deposits in her specimens.
Mm-hmm.
There was almost no cellular invasion, none, quite frankly, in her specimens. And her death was from a generalized form of hemagglutination, of capillary insufficiency in kidneys and lungs. She had clear lungs, and yet we had to intubate her and put her back on a ventilator. She had become hypoxic from microinfarcts in her lungs. And the same was true of her brain. And these little infarcts, representing maybe 10-15% of the capillary beds of her organs, were present everywhere. In fact, her heart was the last to get. We didn't even have her heart. She wasn't on inotropic support until the last few hours of her life. And yet her life had been waning for 2.5 days from all this other that was going on with her.
A systemic.
Yeah. Now, perhaps we could have exchanged her again.
Mm-hmm.
We just couldn't understand what was going on with her. It was like nothing we had encountered in the lab because of the way it presented itself. And I suppose we missed some opportunities with her.
Well, it's a difficult time, that one. Obviously, I've read the papers and studied your thoughts on it as well. I mean, do you feel like we've developed an understanding of those events, or do you think that as time goes by, there will be a chance to study some of those again?
Well, I think without doing that same experiment again, it's going to be very difficult to know.
But I mean, are there tissues that can be re-examined from her case as we learn more about
Yes.
potential immune causes of her?
We do have lots of specimen left that we could evaluate. We were going to try to use a lot of it to try to look at the transfer of infectious diseases.
Right.
And twice I thought that the CDC was going to help us with some of that. And about the same time, the anthrax scares came up, and we were on the back burner again.
Sure.
But I think that her residual specimens would be most useful in studying the infectious disease transfer potential
It could be,
of
couldn't
cross
it?
species.
Yeah. So, as you say, the criticism, well, mounted, and I'm sure was teased apart and discussed at every possible level. And I guess the question arises: Would you do the same? Would you go through the same steps again? Or
You know, I've asked myself that question. I think we probably would have if we hadn't had an opportunity to do an allograft.
yeah.
The allograft sort of stopped the xenograft effort.
Well, let's talk about that a little bit, because that really set the stage for the whole development of the field. And one of the things I've always wondered was, did the events surrounding baby Faye, they must have tested your resolve that infant allotransplantation was ever going to move forward successfully. And I mean, you're really to be commended for continuing on that effort.
You know, I never lost enthusiasm for the idea. I was absolutely sure we were right that these babies would benefit from transplantation of some sort, whether that was going to be cross species or allotransplantation or what. I wasn't entirely sure of that.
But the next year brought resounding success, didn't it?
Well, it did. I hadn't lost any enthusiasm, and I got a call just serendipitously one day from an individual I had met in Northern California, an obstetrician. And he said that he and his partner had a baby born with birth asphyxia. They were absolutely sure it was about 6 or 7 days out. They were very sure the baby was brain dead and would be a useful donor, and that the parents would like that. Were we still in the transplant business? That just came right out of the blue.
So this would have been sort of 6 or 8 months later?
That was a little over a year later.
Oh, it was a full year
in
later.
November
Okay.
of the following year.
Of 1985.
And we were still down in the lab, and we were still transplanting, and we were still trying to learn what we could from baby Faye before re-upping the protocol again, which we were prepared to do, I think.
And so that happened in this case.
And then the allograft intervened. And then we kind of lost track of the xenotransplants for a while we tried to get some traction with allografts. Anyhow, those parents permitted us to bring the baby down and do the first allograft that we had done in a newborn. And that sort of changed the dynamic. It did quite a lot, as that baby did well.
Right.
And then there was another one. And by that time, then we asked the procurement agencies to start taking an interest. And they did. And before you know it, we found a donor for another one, and then another. And then other procurement agencies had to take notice, and it got a life. And we did get some traction with allotransplant. And just trying to keep up with that exhausted us.
Yes, because I mean, within a couple or 3 years, there was tremendous success in this. I mean, really, you single-handedly opened the doorway to successful transplantation of infants. And I know that your numbers are changing all the time, but it's over 300 or so transplants that you've done by now, right?
Yeah.
In these babies. And it's not only the mechanical side of implanting a heart, but it's the building of a team. And as you said before, these are these all have to be pediatric. All these issues from a neonatal perspective have to be re-explored, you know, in a team fashion. So donors, the surgical procedures, the intensive care management, the transportation issues,
all that. But there, yeah, I think we sensed there was a level of excitement about this on our campus by that time, at least.
Mm-hmm.
We'd kind of gotten through the baby Faye business, and we were clearly settling in on something that everyone could identify with. Even though there were some misguided people trying to pick at our place and everything with the allograft as well. Whether they were confused about what heart we'd use, I'm not sure. But there were some lingering issues with baby Faye, even with the allograft startup. But boy, once we got some traction, I'd like to say, by the early 1990s, one year we did 65 or so transplants, and trying to do the rest of the work that was needed. You know, we were killing ourselves.
And the institution clearly was standing behind you with the resources necessary to build that team and that effort.
And I'm forever grateful to Loma Linda for doing that. Now, I suppose any institution would have come around eventually, but I never had to worry about that happening. There were people that took the lead all around me that helped bring it all together. You know many of them.
Yeah.
And I was just struggling to keep up with what I had to get done.
So rapidly then, around our world of pediatric cardiology and cardiac surgery, this became something very, very, I mean, a real option that you could offer families where there was little hope. Surgical palliation continued to improve as well, of course, and by, I suppose, the early to mid-90s, there were maybe more than one option, but that really changed the dynamic, didn't it?
Yeah.
As more centers started doing transplants.
For about a decade, it looked like it was going to be really a promising thing. The question was always how to get enough donors to make it really useful, rather than just exceptional therapy. But we knew by that time that the transplants were sticking. The kids were growing, and we were learning a lot about how to get them to grow.
Well, and as well, yeah, so suddenly we're talking about things have to be explored in terms of how big a donor can you take, how small a donor can you take, how far can you go. And I remember having discussions with you over a difficult case from Toronto, and you had just, and you were pushing some of these things so into territory that had never been pushed before, and discovering that, yes, the ischemic time can be much longer, that these infant hearts seem to tolerate an ischemic time that an adult heart would never have worked with, right? I mean, as far as
that's what we were
9
led to
and 10
believe,
hours.
but since most of my experience had been with little babies, I didn't see the limitation. And so we just kept, if we got a call to Nova Scotia, we would go to Nova Scotia, by God, because we had not found the limit on ischemic times, for instance. We didn't know what, quite frankly, we learned the hard way what the limits were on size, whether you could put a 3-year-old heart in a newborn baby. Could you really do that?
Yeah. Or diagnosis, heterotaxy syndromes.
All that. Exactly. Could you put, what about situs inversus? We ran up against that in congenital heart much more often than you would out in the ordinary world of transplantation. And we just sort of took it as it came. And had energetic people around me too that supported the notion of doing all this and really helped out a lot.
Well, I think the idea, as you said, of this finding traction,
Yeah.
because then it probably felt like there were limitless opportunities. Obviously, there were limitations to the number of donors there would be, but on the recipient side, the fact that this procedure, the surgical issues were not going to be the limiting factor.
Right.
The medical issues, by that time there was effective immunosuppression, and so it's really an amazing tour de force, I think.
Yeah. Well, it made quite a difference in the numbers of heart transplants being done nationally, at least, if not internationally. Most of the growth area was in this infant age range
Right.
for a number of years. Now, that may have changed in more recent time, I don't know, but it added a new level, a whole new sector of transplant that wasn't available before. And I'm pleased to tell you that first little allograft will be 26 years old this fall, still going strong.
Well, now there's another
Same
interesting
heart.
thing. Same heart, and these infants, I mean, as you know, transplantation as an infant confers an advantage
Oh, yeah.
that cannot be found in patients transplanted at any later time. I think that's pretty clear by now. And so the decision-making as surgical palliation has improved, I think it's really made for interesting decision-making, because those palliated children, many of those will eventually fail and require transplant at a time when it's much less immunologically advantageous.
Absolutely true. We probably need to reconsider selecting some babies for transplantation.
For primary
transplantation. I don't know how to make those decisions.
It's a
just
tough
yet.
one, isn't it? Yeah.
As we've become so accustomed to doing palliative reconstruction, and that has saved so many babies' lives.
Perhaps as we continue to understand the immune system and are able to take advantage, more and more advantage of the naivety, the immunologic ease of the infant, we'll be able to make decisions about selection for those rare donor hearts.
Yes, perhaps so, yeah.
The other thing I wanted to ask you about is the advent of VADs for children has again changed the field, hasn't it?
It has.
How do you see that? I mean, now we can support a child for a year, 2 years on a VAD, even very young children with the new Berlin heart devices. And how do you think that's going to add to the complexity of our decision making for these children?
Well, it does just that. It adds a complexity, because those infants would have died without a VAD.
Or been supported on ECMO for a little while and been transplanted as a sicker
Perhaps.
patient.
But you know, not a lot of infants get transplanted off of ECMO.
Mm-hmm.
They just don't go long enough
Right.
to get it. And so, whereas VADs, they can go for quite a while. We have to change them out and everything, but they conceivably can go quite a while. I was talking with Bruno Reichhardt, and I think they have a child that had gone over a year on a Berlin heart,
Yeah.
an infant.
We have a few as well that are
Yeah.
out over a year, and it just changes.
It just adds to the conundrum a little bit until we figure out how to improve the donor situation.
Well, we may
You've come a long way at trying to maximize those donors that are available. The key now is to try to find more donors. There are plenty of potential donors.
Well, that's a whole other issue, isn't it, that contributes to this,
Yeah.
as you say, defining brain death better in the infant population when it occurs, taking these inevitable sad cases of perinatal asphyxia that never actually reach current brain death criteria. Are there better ways of defining those that truly have no hope of recovery, or the experience from one of your colleagues, Mark Pusak, who pushed us a little forward a bit more,
Sure.
looking at potential donation after cardiac death for infant transplantation.
We're certainly moving in that direction, but it's going to be slow, I think.
But I guess as we come back to that question then of, it's finally helpful to be able to sit down with these families and have something to offer them
Yeah.
other than the fact that their baby has an unmanageable problem that cannot be helped. And I know from both of our experience over the last 20 years, that's certainly a better place than we were 20 years ago.
I think we have moved the pendulum a little bit forward. Lots further to go.
Lots further to go.
There's pleasantly a lot of energetic young people at a meeting like this that see that and have that vision and can perhaps take it to the next level.
What do you think the next big steps will be?
You know, even learning how to diagnose rejection has yet to find a life. And I'm not sure that there will be a big step. When you ask a question like that, it gives me pause. I think it'll be more little steps from this point on, unless we can find a way for discordant species to work. My own view of that is, and it could be a big step, is if the discordant cross-species technology, the pig to human, pig to primate, were to find its way into the newborn, then we might make some progress. But we haven't done that.
I think I agree with you. I think that's where, if that step will happen, that's going to be a major paradigm shift, I think.
That might partially answer your question. I don't know.
Well, it's been a great pleasure to chat with you, and I very much appreciate your willingness to share some of these thoughts and recollections with us.
Honored to sit down with you, Lori, and chat like this. It's fun.
Thank you very much.